Okay, so as everybody is being brought in while they've been waiting, I want to just thank everybody for showing up tonight. I know it's a little bit early on the West Coast, and those of us on the Central and East Coast are kind of wrapping up our days. I'm really excited tonight to introduce Dr. Kathleen O'Neil-Smith. This is going to be a webinar that I think that we're going to get so much information from. She is incredibly experienced in this subject. And if you don't know already, we did just recently launch a handful of tests this past Monday to measure urinary and saliva hormones and neurotransmitters. And so we thought, what better way to bring these tests on than to bring on somebody with such a significant background in these subjects. And so Dr. O'Neil-Smith, I'm going to turn it over to you, and you can kind of introduce yourself, tell us a little bit about how you got where you are and how you practice, and educate us.
Awesome. Well, welcome all, and thanks for being here. Sarah, thank you so much. I'm so excited about this testing because it's been several years since we've had testing like this available to us. And I used to use it all the time. In fact, it was part of my initial panel for every patient, along with hormones and along with micronutrient testing, etc. But I've been, in a situation where I've had to guess without testing. I can get some precursors, I can get some metabolites, but I haven't been able to get these neurotransmitters, and they are so important to understand from as many angles as we can. So I'm delighted that Vibrant America now is bringing this panel back, and it's cheaper than it used to be. So I can tell you it's a great test, and I'm really excited to be teaching you. So it is really important, and I think the best thing about this Vibrant America testing that's now available is that we can test without guessing. And I've been doing medicine long enough in particularly functional and regenerative medicine for a good 13, 15 years. And having done this for so long, I have learned not to believe everything that I think. And I have learned that I need to test and not guess. Because if I get baseline testing, it's absolutely going to help me help my patient. And that's the reason I'm here. So just a little bit about me. I basically, way back when in undergrad studied nutrition and exercise physiology and was an athlete and raced on the rowing team in my local college, and then also raced on the US rowing team and then coached the rowing team. So I learned about the body and how to optimize the function of the body and make it perform like, the awesome machine that it is. And then ultimately I went to medical school here in Boston, and then did some training, and I really wanted to delve into the body a little bit more. So I did some pathology training initially at MGH, Mass General Hospital in Boston. And then I did my internal medicine training at the Brigham and Women's Hospital. And subsequent to that, I basically have been, in the gamut of hospital-based medicine, internal medicine, end-of-life medicine, kind of all different aspects of medicine while I learned and took on this functional medicine training. And then ultimately in 2008, I took the A4M boards and basically have never looked back. So right now, I would say that my goal is to produce optimum wellness in my practice, but we do that through the lens of disease and symptomatology, chronic symptoms. And so generally people don't come in when they feel well, even though we all know that the absence of illness does not mean that you are well. Meaning if you don't have a particular disease, that doesn't mean that you're not going to get one. So again, having these baseline measurements, whether it's hormonal or neurochemical, neurotransmitter, is really, really valuable. So in my practice, patients come in with many symptoms. A lot of them come in with sleep disorder, fatigue, anxiety, depression, sleep apnea, and you've got to ask about a lot of different things, and gut issues, of course. So all of those things are very, very common, and we'll look at symptoms in a second. But when they come in, I always have to know, why are they there? What do they want me to do for them? Because if I'm not thinking about what their intention is for seeing me, I'm going to have a difficult time helping them, and also building a rapport with them so that they continue to come back and that they actually do get well. So generally what I do when people come in is they come in with either a disease. It could be neurodegenerative, it could be multiple sclerosis or something like that, where they have a demyelination, an extreme condition in their 20s with demyelination. They could have a traumatic brain injury. They could have an autoimmune condition, which we know is on the rise. They could have a standard chronic inflammatory condition, but often people don't see me for the standard American diseases of, type 2 diabetes and heart disease, because they're kind of in a different conventional system. They may see me if they got diabetes, type 2 or type 1 or some in between MODY, mature onset diabetes of the young, if they had a diabetes induced or blood sugar abnormality induced by steroids, taking prednisone for lung issues or something like that. So, they're always going to come in with some symptom, some reason that they want you to help them. And it's really important to be thinking about that. And I think probably the most important diseases that we have to be thinking about, certainly with respect to aging, is, how is their brain? How is their vision? How is their memory? Those are both brain issues. Both are going to be neurochemically, hormonally, and immunologically all related. And then they're going to want to sleep well and be able to restore. So rest and restore and rest and repair. So we have to be thinking about why the patients are coming in. So we'll look at that in a minute. But that's basically my practice. I've trained in brain injury. I've trained in peptides and have taught many courses and many certification courses on peptide therapy and stem cell therapy and exosome therapy, et cetera. But the basics always have to be ascertained in terms of biomarkers prior to determining what you're going to do. So using these biomarker testing that we're going to look at tonight is really, really, really critical. When I see my patients, I'm always thinking kind of in a foundational approach. So what I want to know is that their body, their systems are all functioning on a solid foundation. And that solid foundation will involve micronutrient testing. That micronutrient testing is going to lead to, how do we fix neurochemical imbalances that might be causing fatigue or anxiety or depression. It also will help us with the hormonal, so neurological, as you see at the top of the screen, looking for the root causes. The micronutrient testing will direct us to whether we need to be in the neurological system, the endocrine system, but ultimately this neuro-endo-immune system is the super system throughout the body that will direct us, these three little overlapping Venn diagrams, to the root cause of symptomatology that the patient is experiencing that will ultimately lead to a chronic disease state that may ultimately become more and more complex. So we really want to be thinking, from a root cause perspective. It is likely that the immune system is ultimately what is being affected by the exposure to many, many triggers. So there are many triggers that we are chronically exposed to, thousands of them, trillions of them, so much foreign exposures daily that are going to lead to immune responses. But those immune responses are going to be realized through the neurological or the endocrine system. So you're really going to have to look at the neurological response, which is going to cause symptomatology if there's imbalances, too much, too little, or imbalances, if there's too much, too little within the endocrine system, which includes insulin, which includes cortisol, which includes aldosterone, which includes thyroid and all of the other estrogen, progesterone, testosterone, et cetera. We're really going to be looking at how do we understand these particular root causes. So next slide, Sarah, please. So when we think about symptoms, we can look at these symptoms that we can, kind of ask our patients about. And I always give my patients a symptom sheet. Every time they visit me, they fill out a symptom sheet. And it goes through each system. It goes through the digestive system, the emotional system, the memory and the brain concentration system. It goes through skin and gut and joints and muscles and sleep. And all systems are included in looking at symptoms. So you can get these online. You can get them through the Institute for Functional Medicine. You can get them anywhere you want, but you want to understand systems-based biology and look at, have your patients grading their symptoms each time they come, because otherwise they're not going to remember. So some of the symptoms of hormone imbalance are here, and you'll note when we go to the next slide, not yet, but that they can overlap with symptoms of neurochemical imbalance, because there is an intimate communication and an intimate relationship between the hormonal system and the neurochemical system. So hot flashes could be a hormonal imbalance, something as simple as an estrogen-progesterone imbalance. It could be from waning estrogen function. It could be from cortisol. So you can get something really distinguishing between hot flashes and night sweats is pretty key. I've had patients who come in and they say, I have night sweats and I have a hormonal imbalance, and I'll ask them to describe their night sweats, and I'll realize that their sweat is likely a neurochemical imbalance. And so I'll say, you really don't have a hormonal imbalance, you have high cortisol levels at night, which is more neurochemical. We want to treat that before we go to the hormones to get better symptom relief. Headaches can be either neurochemical or hormonal or both. So you want to be understanding and measuring and testing without guessing, so that you go down the best path in the beginning to gain relief of your patient's symptoms and their trust and the rapport with them. Hair loss can again be either hormonal or neurochemical. Some people are always thinking hair loss is related to thyroid. Well, in my practice, I actually find that hair loss is rarely related to thyroid, that it's often related to cortisol and some of the other metabolites of cortisol. So really thinking about, and the micronutrients that will result as a result of having high cortisol or a depressed cortisol, because chronically it's been high and now you've reduced your levels and your reserves, and you now have a level of adrenal fatigue. So it's really important to be thinking about these. Look at this list, think about why your patient is there. Are they there for sleep? Are they there for anxiety? If they have anxiety, you're certainly going to want to try to fix their sleep first, because fixing their anxiety is not going to be the likely way to fix their sleep patterns. The sleep will be a little bit different. So you're going to want to look at these different pathways from a hormonal and a neurochemical and a micronutrient testing basis to kind of understand where are the biggest leaks, where are the biggest imbalances for the symptomatology that this patient is presenting with. So let's look at the symptoms of neurotransmitter imbalance. You can see fatigue, insomnia, which is the same as sleep disorder, behavioral disorders, low libido, we saw that on the former page, migraines or headaches, we saw that on the former page. So when we're thinking about this neuro-endo-immune system, this super highway through the body, I tend to think in two ways. One, I told you about the little pyramid that I'm thinking about foundationally, micronutrients, and then as we go up this pyramid to things that we want to be correcting, first micronutrients, secondarily hormones and neurochemicals, neurotransmitters. Third, we want to be addressing if there's any kind of peptides or other things that we have to replace in order to get soft tissue healing, like a body protection compound, BPC. And then we want to, think about exosomes and stem cells. But the three at the bottom, the micronutrients, the hormones and the neurochemicals, neurotransmitters, are essential to be recognizing before we proceed up to the top of that triangle. When a patient presents with symptoms, neurochemical, as you see here, or some overlap with hormonal, you're going to want to think, is this patient primarily inflamed, and look for inflammatory markers. You're going to want to think, is this patient neurochemically impaired or neurochemically imbalanced? Do they have enough serotonin? Do they have enough GABA? And obviously we know that serotonin is made in the gut, so we'll have to think about the gut. But we can start by looking at neurochemicals and seeing where those deficiencies lie. Is it dopamine, norepinephrine? Is it adrenaline? Is it GABA? Is it glutamate? And we'll look at some of those in a few minutes. So you're going to think inflammation, immune dysregulation, and oxidative stress, and then look at the neurochemicals to see how those have been impacted. The nervous system is the key system. Many of us think about the vascular system often because we're taught, to really treat the vascular system. There are many different medications that base our understanding of pathophysiology on symptomatology on the vascular system or the blood vessels. And the blood vessels certainly are important. But if you were to put a blood vessel and a nerve together in a tissue, and the nerve were to go off to the right, the blood vessel would follow. The nerve doesn't always follow the blood vessel. The blood vessel is more likely to follow the nerve if you're doing experiments at the bench or in the lab, PhD lab. So it's really important, I think, to understand that. So I think that the neurotransmitters will be critically important. And one of the things about that is that when you think about the vagus nerve, many people are overstimulated and their vagus nerve is unable to respond appropriately. So the vagus nerve is very central to the anti-inflammatory, keyword anti-inflammatory, cholinergic pathway. And the anti-inflammatory cholinergic pathway will be very central to keeping inflammatory chemicals or inflammatory cytokines in check. So one of the things that you'll know when we get to this on the neurochemical testing is that acetylcholine is brilliantly measured in this particular testing. And it's really important because acetylcholine is one of the primary signals to the brain when there's an exposure to a trigger, to an infection, to a toxin, to a food peptide that the body can't metabolize or process, to an allergen, to a medication, to an autoantigen. Acetylcholine will be a very key signal that there's been a trigger or an antigen exposure. And the interesting thing about that is that when you've been exposed to a trigger that will trigger a neurochemical and a hormonal imbalance, you will get a signal through the afferent back to the brain, to the HPA axis, hypothalamic pituitary axis, that there's been an exposure. And when the HPA axis understands this through the vagus nerve, it's going to release anti-inflammatory hormones appropriately. And those are going to include cortisol, dopamine, adrenaline, noradrenaline. Those will be able to be measured in your neurotransmitter panels. And the interesting thing about that is that's an appropriate response to a trigger. The problem is we don't turn off that response. If we turned on that response and turned off that response when the problem was taken care of, we wouldn't need to do this testing, but we get this runaway problem of cortisol being excessive, of adrenaline being excessive, of noradrenaline being excessive, and dopamine. And we see ADD, hyperstimulation, anxiety, up and down, bipolarity. We see fatigue at certain points during the day, and the adrenal gland becomes more and more dysfunctional with respect to the cortisol and the adrenaline and things that are coming from that. It will affect energy, it will affect sleep, it will affect behavior and reward-based behavior as well. It will affect your hormones, it will affect your weight, it will affect your mind and your focus and your concentration and your memory, and how you feel about life in general. So it's really important to understand that. The issue is that acetylcholine, which is again one of the neurotransmitters that is measured, when it gets released, it's supposed to go down from the HPA axis through the vagus nerve and increase binding of this acetylcholine to white blood cells. Because if white blood cells will have a certain number of receptors, let's call it 10 for acetylcholine. And when white blood cells get activated by a trigger, the immune system gets activated by a trigger. If the white blood cell is fully bound, these receptors in the white blood cell for acetylcholine are fully bound, you will appropriately turn off the inflammation. But often these acetylcholine receptors are unbound, and you end up with a runaway inflammatory system with inflammatory chemokines and cytokines that basically create neurochemical imbalances that result in the physical symptoms, the pain, the joint pain, the headache, the belly pain, the mental symptoms, the focus, the memory, the confusion, the sleep difficulty, and some of the emotional symptoms like sadness, anxiety, irritability, and a reduced response to stress. So those are like the basic symptoms that we generally will see. So it's really important to understand what this testing will do. And just to give you a little tidbit, if somebody does have reduced acetylcholine to bind to those receptors on the white cell and not to contain the inflammation, we can give them acetylcholinesterase inhibitors so that we increase the acetylcholine that's available, which would be huperzine A. We can give them alpha GPC, which will provide choline and is a precursor for acetylcholine. We can give them acetyl L-carnitine, which will provide the acetyl group, and that way there we can restore acetylcholine. So, it's really important to understand that the way that all of this works, and that's a really basic and incredibly important understanding for when somebody is exposed to a trigger, or there is a trigger that activates a cascade of events causing their symptoms and ultimately a chronic disease. Next slide. So here we have overlap of many of these symptoms, the neurochemicals and the hormones. They are intimately connected. There is no way to affect a neurochemical without affecting a hormone in the long run. There's no way to affect a hormone and to reduce a hormone or overproduce a hormone. In a woman, if they have too much testosterone, that's going to shift the neurochemicals. If somebody has too much dopamine, that's going to ultimately shift the hormone. So we have to understand the interaction of these particular systems and how they're interrelated and overlapping. And that's why kind of measuring from the baseline the micronutrients that provide the building blocks for neurochemicals and hormones is so important, but then also to look at where is the biggest hole in the system. Next slide. So here we're going to look at hormones. So this is a pretty complicated slide. Many of you may have seen it. I think that there are a couple of key points that I'll make about this, and then I'll give you some other pearls, in an advanced way. But the key thing about this system, I will divide it into the upper left, cholesterol, pregnenolone, progesterone, and the blue on the left. And then the upper right, deoxycortisone down to cortisol, 11-deoxycortisol, cortisol, and cortisone. So that's a second avenue. And then we'll go down below to the pink. So when I think about this graph, I think that the upper left, the cholesterol through pregnenolone and progesterone, that has to be satisfied as a basic need. Like, this is one of the most basic needs. So cholesterol is the backbone of many of the steroidogenic hormones that our body needs. When I look at the upper right, I'm giving you an overview right now, the deoxycortisone and the cortisol, the upper right, halfway up on the right to the top, we're looking at a catabolic picture. In order to be whole, we have to break down, build, break down, build, break down, build, right? You go to the gym, you break down a muscle to build it back and make it stronger. So we've got the upper left, which is our building blocks phase. And then we've got the right, the middle and up, which is the catabolic phase. We've always got to be breaking down in order to rebuild. And then when we look at the bottom, DHEA, androstenedione, DHEAS, and the rest, estrogen, progesterone, estrogen, and testosterone, we're thinking about our anabolics. So those would include our 17 keto steroids, which are on the left, and then our hormonals. So when you're anabolic, you are in a prolific state. You can procreate. You can make a baby. But if you're catabolic, and you're way more catabolic, the upper part of this chart, you are going to have a difficult time getting pregnant or building. So as we age, we will be more catabolic than anabolic, but we always need to be maintaining the left side, the cholesterol, pregnenolone, as the building blocks of this. So it's three components: the building blocks, catabolic, and anabolic. Ideally, we have perfect number of building blocks, cholesterol, pregnenolone, etc. And we have a balance of catabolic to anabolic 1-to-1. That never happens. I would say with the multiple exposures that we have now, and the chronicity of these triggers in our environment that we're exposed to, we are much more catabolic and much more overstimulated and excitatory because of the vagus nerve can't keep up, and even less acetylcholine because it's needed for other reactions as well, that we will be way more catabolic than anabolic. So we want to look at this chart to understand, are we catabolic? Are we balanced catabolic, anabolic? And do we have the building blocks? Now, whenever you have a need on outside of the cholesterol pregnenolone, if any of the things in the rest of this diagram are not, we have a need for, whether it's cortisol, DHEA, and the 17 keto steroids that are going to help us rebuild and restore and repair, or testosterone or estrogen or progesterone, we will have a feedback cycle that will increase our cholesterol. So I don't really find an increased cholesterol, at 200, a level of 200, to be a dramatic problem, particularly if I'm looking at this graph and understanding the biomarkers for a particular patient. If they have a big need for cortisol, or they're, in perimenopause or postmenopause, or in andropause for a man, then I'm going to certainly know that they are going to have a higher cholesterol. So understanding this is really important. Pregnenolone and DHEA, pregnenolone in blue and DHEA in the red, are really important because when there's remarkable stress or stressors to a patient, they're going to have a very big need for pregnenolone to supply the cortisol system or the catabolic system. And so pregnenolone is often something that I'll use at night. You can measure it and you can restore it. And even if you don't measure it, you can use pregnenolone readily at night to help the HPA axis or the adrenal gland to recover at night. And you can use, just basically 30 milligrams of pregnenolone. There are a lot of good companies out there that make it. And DHEA, by measuring, you'll know that you may need a little bit of DHEA. So when we're under inordinate stress, we'll get a cortisol steal syndrome. We will steal all of the cholesterol building blocks towards cortisol, and we'll reduce all of those hormones at the bottom of the chart. You cannot be breaking down and building up at the same time. You can have a one-to-one, but that's the best you can have. So DHEA may need to be restored as well if somebody's under inordinate stress. So looking at the cortisol pathway is critically important to understanding where somebody is. Are they in the acute or subacute phase of stress where their cortisol is elevated? Or has it been so chronic that the cortisol is now low and we really are in a late stage of adrenal fatigue? You definitely want to give them pregnenolone. You may want to give them progesterone. When we look at the bottom part of the graph, we're looking at the hormones, and we certainly want to know their 17 keto steroids, the DHEA, and then their balance between testosterone and estrogen, and then early on progesterone as well. This chart is wonderful because it also shows you at the bottom left the estrogen metabolites. And estrone, down in the middle on the bottom, kind of towards the right, estrone E1, is not the most beneficial and the most anti-inflammatory of the hormones. In fact, depending upon what our genomics are and how we metabolize it, it may actually be disease promoting or quite pro-inflammatory. So looking at the metabolites of estrogen in terms of the 2-hydroxy, 4-hydroxy, 2-methoxy, 4-methoxy, 16-alpha-hydroxy E1, and estriol is really important. And the essential point on this graph is that the bottom right, estriol, E3, 2-methoxy, and 4-methoxy are desirable. So when we find higher levels of the middle part of those pathways, the 16-alpha-hydroxy, the 2-hydroxy, and the 4-hydroxy, when those levels are higher than estriol, 2-methoxy, and 4-methoxy, we know that we're going to need some methylation in order to move those to non-toxic metabolites, because the 4-hydroxy and the 2-hydroxy will be inflammatory promoting and will absolutely be associated with higher inflammatory states and higher inflammatory disease states like stroke, heart disease, diabetes, you name it. So this has been written about in the New England Journal back in the early 2000s with respect to these metabolites and understanding the genomic pathways, the cytochrome P450, the methylation pathways, the COMT. And when we understand these pathways and we look at these numbers, we can absolutely intervene and reduce inflammation and reduce the the progression to chronic disease, particularly if there's symptomatology. So this is just a really, really wonderful way to look at hormones, to understand the precursors. So if we're taking estrogen, testosterone being a precursor, the metabolites, the 16 alpha, the 2 hydroxy, the 4 hydroxy estrogens, the 2 methoxy estrogens, and the 4, and understanding like how are we going to restore balance and create a little bit of breakdown or catabolic activity and a little bit of anabolic activity to rebuild and restore. But the basic building blocks are the cholesterol, the pregnenolone, and the DHEA sulfate for a lot of this, but you've got to look at this chart to kind of understand that a little bit. We'll come back to this with some questions that you might have. So this is really important, perimenopausally, postmenopausally, and if anyone has breast cancer, male or female, or difficulty with, or prostate cancer, difficulty with being periandropausal, meaning low testosterone in men, or perimenopausal, or having difficulty with fertility in women. So next slide, please. All right, and so this is it in a linear fashion. All of those things in the graph you're seeing here in a linear fashion. Current results, previous results, and reference ranges. So we don't really have to look at that because we just saw this. And this again is looking at urinary androgens, urinary progesterones, anabolic chemicals like DHEA and androstenediol, which are right in the middle. And those will be really important for anabolic pathways. Next. And then the glucocorticoids, looking at this. And if you just gestalt this, when you see this for your patient and you see that things are in the red, look at the cortisol and see, is it high or is it low? Again, if the cortisol is high, it gives you a sense that this is not a massively chronic state, or even in a chronic state, the patients are, essentially able to get some restoration and some resetting, probably through the neurochemicals, if the cortisol has been chronically elevated. But normally, after being elevated, it's going to come down to normal, and then it's going to be subnormal, and they're going to get into a more flatline state. So you can see the level of stress by looking, and the chronicity, the acute or chronic nature of the stress, by looking generally at these numbers here. And 8-OHDG, the oxidative stress marker, is really, really important because it's going to give you a sense of cell turnover. And you're really going to not want these cells to be turning over and releasing their DNA content, the 8-hydroxydeoxyguanosine content, so that they're basically not able to restore their cells. Their cells are breaking down more than they're able to restore. So they're more catabolic than anabolic. And the urinary free diurnal cortisol I love because it gives you a sense of the first morning cortisol, which should be the peak cortisol. We should be waking up with our peak cortisol level. And then throughout the day, as we're experiencing being awake and doing doing whatever it is we're doing during the day, we're basically looking at our response to stress with respect to cortisol. So you can really see, if the peak cortisol is low, you're going to have to absolutely restore that. Cortisol at night is really important because we should really have a very low level of cortisol as we try to rest and repair, because cortisol will, if it's elevated, it's going to interrupt our insulin regulation. We're going to become insulin resistant. We're going to gain weight at night while we're sleeping when we're insulin resistant. High cortisol will cause high insulin. You can have a normal blood sugar, but it will cause a high insulin. And it will also impair growth hormone activity, which again is restorative as we're sleeping. So the diurnal, or the cortisol levels throughout the day, are really important to be looking at to understand how chronically unwell a patient is. When all of these numbers are low, that means that we've got a flat line essentially for cortisol release, and we really have little ability to adapt to stress. So very important to be looking at. Next. Those are saliva, same thing. And here we're seeing the diurnal pattern as we just described: first morning, second morning, evening, night. And it should fall between those orange lines. And if it's outside of the orange lines, then it's abnormal. So this is really, really important. Melatonin is really important. And I love that we measure melatonin because with the overstimulation in this reward-based society that we're living in, you get a text, you respond to a text, you get another text, you respond to a text. That's all dopaminergic activity. We're increasing our dopamine and our cortisol levels regularly with this in, where we are with respect to the internet today. But the interesting thing about dopamine is that melatonin will inhibit dopamine. So melatonin is absolutely delicious. So understanding the body's melatonin levels is really, really important. So not only will melatonin inhibit dopamine and be neuroprotective, but it will also inhibit glutamate. And glutamate can be very neurotoxic and very neuroexcitatory and really just deplete you and cause memory impairment and focus problems, etc. So really important to understand all of these particular numbers. Go to the next slide, please. So neurochemicals, great. I think we have about 10, 12 minutes left. Glutamate, we talked a little bit about glutamate. Glutamate is really important for energy, for appropriate energy, and glutamate will bind to your NMDA receptor, your AMPA receptor. It will bind to many receptors, and it's really important for focus, concentration, learning, and long-term memories. When glutamate is elevated, it means you'll likely have a lower GABA, and GABA is your endorphin. GABA is delicious. GABA is your benzodiazepine, to not let the accelerator drive you or the stimulation drive you. Glutamate is really, really important. When glutamate is elevated, and it's so essential to be looking for this, it will cause a cascade of destructive molecular events. And especially within your energy systems or your powerhouse of your cell within the mitochondria. And some of the diseases that you'll end up with is Alzheimer's disease, memory impairment, ALS, multiple sclerosis, epilepsy, headaches, migraines, schizophrenia, bipolarity. So glutamate is a really important neurochemical to understand. And what we can see is that glutamine, which is so deliciously healing when you've got the appropriate cofactors like magnesium and manganese and vitamin B6, you will be able to take that glutamine and use it to create GABA or the endorphins. Now, one of the things about vitamin B6 is that you can see the pantothenic acid and vitamin B6 are critically important for neurochemical metabolism and for taking any amino acid and using it appropriately to get to the ultimate neurochemical. In this testing, we measure xanthurenic acid, which is the precursor to vitamin B6. And when XA, xanthurenic acid, is high, which we'll look at in a minute, you will know that you'll need a lot more B5, B6. So that's the first thing I look at in my testing to understand, what's going on with GABA and some of these other GABA, serotonin, you name it, because many of the neurochemicals will require vitamin B6. And if you don't have adequate, you will not be able to create a balance with some of the inhibitory or kind of calming, soothing, rest and reset neurochemicals like GABA, serotonin, etc. So we see glutamine here. Glutamine goes to glutamate, and we don't want to be stuck at the glutamate level. We want to be able to move that glutamate to vitamin B with the aid of vitamin B6 and pantothenic acid to GABA. And that would mitigate the need for all the Ativan and Valium and all of the benzos that people are taking at night. So really important to look at this to see what's going on with that particular endorphin or enkephalin system that's allowing the body to get into a soothing state. You're looking at cortisol, you're looking at hormones, and you're looking at GABA to try to understand what will allow the body to get into that state. Glycine is also inhibitory, and glycine is really, really important for detoxification. So we should look at glycine as well as an inhibitory neurochemical or amino acid that will allow us to use serine. And then our phosphatidylserine is really going to be soothing for the brain if we have sleep disorders. And one of the things that you'll note there when glycine goes to serine is MTHF. And if we look over histamine, we see SAMe. So ME from SAMe and M from MTHF is methylation. So we can get a sense of how we're methylating by looking at these pathways of glycine, serine, glutamate, GABA, histamine, and where are these levels? Are they elevated or are they low? So you just follow If glycine's elevated and serine's low, that means that we're missing something like an MTHF, a methyl tetrahydrofolate, or a methylfolic acid, methylfolate, or a vitamin B6. So if you supply methylfolate or vitamin B6, you'll be able to move along that inhibitory pathway to allow for rest and reset in the setting of somebody having a sleep disorder. And we won't get into histaminosis or mast cell disorders, but this whole histamine pathway is also critically important. And we can see that vitamin B6, which we can measure in this panel, and SAMe are critically important, as well as B2 and copper. Next slide. In order to treat glutamate, if you have an excess glutamate, you would use methylfolate, you would use melatonin, you would use omega-3s or essential fatty acids, and you would use magnesium and vitamin B6. So methylators, anti-inflammatories, melatonin, which is very beautifully inhibitory, and magnesium, and all of those can treat excess glutamate. And in terms of GABA and GABA deficiency, which can relate to anxiety, seizures, etc., we could add again B6, B5, pyridoxine, magnesium, omega-3, and melatonin. So very, very, very similar. Here we're looking at serotonin and serotonin metabolites, and often, obviously SSRIs are used to treat depression. So we're looking at tryptophan as one of the amino acids that can aid in creating serotonin. Tryptophan will not be adequate to cross the blood-brain barrier. You would need more of a 5-HTP. Again, you see the xanthorenic acid up there on the right. When we measure that, we get a sense of the need for vitamin B5, B6. If it's elevated, we need more B5, B6. If it's low to normal, we have adequate B5, B6 for the pathway. But tryptophan going to 5-HTP, 5-HTP is more likely to cross the blood-brain barrier. L-tryptophan is very inefficient. It's a very inefficient way to increase brain serotonin. So we would utilize 5-HTP to make serotonin. So understanding the relationship here, if you have a low 5-HTP, you're likely going to have a low serotonin. If you want to look at the relationship between the serotonin and the melatonin and understand what will you need to add for the patient in the pathway, like methylation, B6, B5, etc., in order to make these pathways run more smoothly and to maintain more balance. Next slide, please. And here are the catecholamines, the stress hormones. This is where, so you'll generally find that the two slides we saw before, the inhibitory neurochemicals are low, and that the stress chemicals are high or depleted. They can both be depleted. When the inhibitory and the stress are, or the excitatory are depleted, you basically will kind of feel balanced. You may not feel anxious, you may not feel depressed, you'll feel more balanced. But when there's an imbalance between the prior two slides, which were inhibitory, GABA, serotonin, serine, glycine, and this slide, which is excitatory, then you'll feel anxiety, then you'll be up and down, and we really want to restore balance. So here we're looking at tyrosine and how that will create dopamine and noradrenaline and adrenaline. But usually there's a runaway system here and we're overstimulated. And we can modulate and move these excitatory neurochemicals along their pathway to their metabolites, the metabolites being, if you look from the top down, HVA, VMA, etc. We want to move these through into their metabolites so that we can make room for more stress excitatory chemicals and not let them build up to the point where we think we're going to pop from anxiety or overwhelm. So in order to move dopamine to HVA, norepinephrine and adrenaline to VMA, we need to have many of these cofactors and enzymes along these pathways. So if you look and see that dopamine is high and norepinephrine is low, you're going to know that a little bit of vitamin C, a little bit of copper, and a little bit of methylfolate, if we look from dopamine to the right and we see COMT and MAO, we're going to know that a little bit of methylfolate, a little bit of magnesium, a little bit of B12 are all going to be necessary to move to dopamine to HVA, if it's elevated because it's not working well down the dopamine to norepi pathway. And we can add copper and some minerals and vitamin C, and that will improve that pathway. But mostly what you're going to see is excitatory chemicals, as you see here, elevated. You want to get a sense of which ones. Is it adrenaline? Is it dopamine? Oftentimes PEA is low, and we need to add phenylethylamine in order to get somebody to feel, a little bit more awake, a little bit more stimulated. Acetylcholine can do that, as we spoke before, and aspartate can do that. So, there's another chemical. Aspartate is another amino acid that we also measure, but that's a whole different conversation. So that's a different pathway. Let's look at the next slide, please. So again, here you're looking at inhibitory or calming, rest and repair, serotonin, GABA, glycine, taurine, and the metabolite of serotonin, 5-HIAA. And at the bottom, you're looking at the excitatory neurochemicals, dopamine, often elevated, norepinephrine, epinephrine, histamine, glutamate, aspartate, tryptophan. These are all going to make the brain on fire. Not so much acetylcholine, but the rest of them. So again, when you've got a dopamine excitatory situation, you may want to be balancing some of the products that we talked about for serotonin and GABA, the methylfolate, the vitamin A, the melatonin, the magnesium. And you may also want to, think about reducing stress levels and how can we go about that. There'll be many lifestyle components to it. You will have to, respond to the overstimulating sources of your day-to-day life, turning your phone off, being able to separate from that and not generating that reward-based neurochemical response, increasing dopamine, etc. So it's really important to be looking at these numbers. I love oxytocin at the bottom of this slide. I use a lot of oxytocin in my practice. Oxytocin is very soothing. It's considered the male moral molecule. I mean, for men who are overexcited and have an overstimulatory aggressive behavior, adding oxytocin, which I do to many young wounded warriors who I see in my practice, they get tremendous benefit from sublingual or nasal oxytocin. It is absolutely delicious. Again, if we look up at acetylcholine, if we add huperzine A, alpha GPC, acetyl-L-carnitine in an overstimulated state, delicious, absolutely delicious for reducing that excitation and making a more rest and repair kind of situation. And just really, really helpful. Pregnenolone can help as well from the hormonal pathway because it can make something called allopregnenolone. Next slide. And these are also some of the other neurotransmitters that are really helpful. They're precursors, as you saw in the pathways earlier. So you can take these numbers, go back to the pathway, and help and learn and understand how you're going to use them. Xanthorenic acid, I mentioned a lot. That will be reflective of the need for vitamin B5, B6, or pantothenic acid. You'll see creatinine, and you're going to want to know that they have normal urinary kidney function in order to be measuring these things. And I would say the vast majority, 99% of the time, they do. So you don't really have to worry about that, but you should look at that at the beginning to know that you're handling that. So let's open it up to questions. Do you want to ask the question, Sarah? Or how do you want to do that?
Sure. Yeah, I can read them off. I'm not sure if you see the little, if they pop up, like the chat or the Q&A, but I can go ahead. There was one already. But everyone else that's listening, if you do questions, if you want to type them in, now would be the time.
Mm-hmm. I'm not
so, whoops, for some reason okay. So the one that was typed in on the chat from Eric, what do you say to practitioners that don't believe urinary neurotransmitter testing is valid?
I don't, I'm not answering practitioners. I'm here to help a patient. So I think the proof is in the pudding. If I do urinary neurotransmitters and the patient is better, I'm not interested in what anybody else has to say. So that's not because I don't really care. The point is, Eric, that I've gone down a pathway of, going through very detailed books and studies and understanding and learning with respect to this. And if they don't want to get on that pathway, that's their issue. It's not my job to teach them. If the patient wants to engage with me and wants to get better, not through a hit or miss program, but through, a testing without guessing, trial and error, I'm going to get the data that's going to help my patient feel better. I expect my patients to feel better post getting biomarkers on them within 3 to 7 days. That doesn't mean they're all better, but I want a positive response. And I want a response that's going to be produced safely, effectively, clinically, cost effectively, and sustainably. And I'm going to do that by getting this testing and not guessing. And if other practitioners don't believe it, then I'm not here to teach them. I'm here to do what I think is the best and the most safe, most effective, and most sustainable treatment for my patient.
Great, that's well put. Would you, I guess maybe as a piggyback to that question, do you feel like the majority of the time when you have a patient, you're looking at their symptom chart that they've filled out, does it match up with what you find on the labs? And that would kind of answer that question of, is it valid or not,
Yeah, I would say that that's a great question, Sarah. The majority of times it's so interesting. People will tell me their story. They come back 3 weeks later, 4 weeks later. I've seen a number of patients in between. I've done a lot of teaching in between. I don't really remember their whole story. Of course, I review it before I see them again. But what I'll do first is I'll look at their biomarkers, their neurochemical testing, their micronutrient testing, and their hormonal testing. And I'll say, what would this patient feel? So I'll do that as a test for myself. And then I'll go back and look at their symptoms. And I would say that it's remarkably consistent, that the testing reveals that. But the interesting thing is you can have fatigue and you can have a sleep disorder. But if you have either of those, there are 10 different reasons that they could have that symptom. So I can look at their biomarker testing and I can see, a low, let's say I can see a low norepinephrine. I can see a low cortisol, and either of those reasons could be a reason for fatigue. So when they don't know the reason for fatigue, they're counting on me to look for it. So if I see a low hormone versus a low neurochemical, I have to kind of discern, and I use my brain, my knowledge, and my heart, my intuition, to kind of understand, based upon their description of their fatigue, where am I going to start first. But I do my treatment plans in phases based upon the biggest holes, the biggest biomarker imbalance. And I don't know what's going to show up. People will often say, well, what's more important? Well, it really is going to depend on A, the story and the symptomatology and what the patient wants to have happen soon, what symptom they want to change, and B, where I find the biggest hole. You can't go wrong by starting with the cortisol versus the noradrenaline, the norepinephrine. You're going to get a benefit. You're probably not going to get a sustained benefit if you only treat one of them. So you start with one. It doesn't really matter. You're doing the best you can, and you're using your intuition the best way you're able to, and you can't be faulted for that. You will make a difference.
Great. Next question, Dr. Marina Franzoni. She said, hello, and thanks for such a great talk. If a male patient has high normal estradiol, low testosterone, and low DHEA, is giving DHEA okay, or should it be 7-keto DHEA?
I usually use 7-keto, but that's not because of the estradiol. I find it really interesting that someone's going to have a low testosterone and a high estradiol. I would more expect their total estrogens to be elevated, and that estrogen to be coming from a source other than, I think it would be coming from the adipose tissue, to be honest with you. So I don't really buy a low testosterone and a high estradiol, but I do buy a low testosterone and a high total estrogen. And I would certainly be thinking about their 5-alpha reductase pathways, and I would be thinking, I wouldn't be ever giving, I would probably, I would certainly use DHEA 7-keto. I wouldn't think that the 7-keto DHEA would restore their testosterone, because in men it often doesn't, but in women, DHEA can restore their testosterone levels if they're low. but it doesn't appreciably, it goes down more the 17 keto steroid anabolic pathway. You know, when people like to take nandrolone or oxandrolone or some of those anabolics in the bodybuilding world, that's more where DHEA is going to go down. And you really can't direct it because it's going to be genomically dictated. So the testosterone, if it's low, you're going to have to come from a different angle with respect to that and figuring out how you treat that. And you might treat it with testosterone, you might treat it with HCG, you might treat it with Clomid, you might treat it with DSIP, you might treat it with progesterone. I think it depends upon the patient, because remember, progesterone is at the very, after pregnenolone, progesterone, those are going to hopefully drive from the very beginning the building blocks, so that every part of that pathway, that steroidogenic pathway, feels like, hey, I got what I need. I got the building blocks. I can go down the pathway I need. I can go catabolic. I can go anabolic. I can go wherever I need in this pathway.
Great, great. She had one other question and asked, is it safe to supplement DHEA in breast cancer survivors if they have low levels of DHEAS?
I think it's malpractice not to.
Okay, great. Let's see, Constance, we have those charts available. Your local, Constance just asked, do we have those charts available? That's actually a marketing resource that either your local territory rep can give to you, or we have them in our portal. If you log into your provider account, they're available under the educational tab. But we can also, let's see, I don't have the ability to attach something to emails that go out from our webinar platform, but there's going to be an email that goes out this week that has more information, and those charts are going to be one of them. So just be on the lookout for that if you get our marketing emails.
With respect to the charts, I can tell you, a picture generally is worth 1,000 words. Those charts, they're gold. They're platinum. They're the best. You need to use the charts, and you need to understand those charts, and you need to look at them from 60,000 feet, and then 6,000 feet, and then 6 feet. But the 60,000 foot view is all about, are we able to break down, which we need to do, and appropriately restore? Catabolic, anabolic. Yep. Do we have the building blocks?
Excellent. It looks like we have one last question before we have to wrap it up. Dr. Franzoni also asked, any pearls for adrenaline dominance?
Adrenaline dominant, I'm just thinking that you are really under significant attack by various triggers, and it's going to wear out. So I think you're really going to want to support from the very beginning all of those systems, all of those pathways, the hormonal and the neurochemical. So you're going to want to do pregnenolone, DHEA, and you're going to want to support cortisol, and you're going to want to get the metabolism of the epinephrine and the dopamine to HVA and DMA. Absolutely. You're going to want to go to the COMT, the methylation pathways, and you're going to want to make sure, I would measure them, to be honest with you. I would know if they were not functioning or they were perfectly functioning. If you have adrenaline dominance, you're likely having a COMT homozygote non-functioning, and you're going to want to know that, because you're going to want to restore that the cofactors and the enzymes that work within that system to move the adrenaline out, and make room for extra adrenaline as you support the systems and look for the root causes and the triggers.
Great, very cool. This was, Dr. O'Neil-Smith, this was a great informative session. I think that this test is foundational, just like you pointed out. If you look at all of those symptoms of hormone and neurotransmitter imbalances, probably every patient walking into a provider's office has at least a few of those.
Absolutely.
And I think, yeah, and I really think you could make the argument that probably to some degree they all have some degree of imbalance in these systems. And it just seems like such a important test to be looking at when we're talking about inflammatory conditions, diseases, the neuroendocrine and immune cascade that you talked about. Well, I thank you so much for your time tonight. This was great. And for those of you listening, this will be available in our portal, as well as a link will go out with the recording. It's usually about 2 to 3 days afterwards, but it's generally up in our portal within 24 to 48 hours. And this also goes out to, the link will go out even if you registered but didn't make it tonight. So if you had friends or colleagues that were looking for it, they'll also be able to get it. So Dr. O'Neil-Smith, thank you so much on behalf of Vibrant. The website that's up there on the slide, that is her website. If you are interested in working with her, I believe you do some training or consulting for providers. Is that correct?
I do some group training on Zoom through
okay.
Do some teaching for peptides and just basic understanding of how to use these panels. And then I also do some directed consultation as well if people need that. So just go to treatwell.com and you'll see that information.
Excellent. Well, I hope everybody has a great evening. Again, Dr. O'Neil-Smith, thanks so much for your time. And everybody, thanks for tuning in.
Thank you.